For this station, like all others, the goal is to get the probe in the student's hand as quickly as possible. So we're going to be using Eve to assess cardiac physiology and then Tamponade on imaging. So as for any image, we use I-aim, I indication, A acquisition, next I is interpretation, M is management. So for your indications for the cardiac point of care ultrasound, it could be a patient has chest pain, dyspnea, hypertension, or it could be part of your extended fast exam. So for your acquisition, you want to use a linear probe. You could also use a curvilinear probe because you're going to have a depth of at least probably 21 centimeters. Use your overhand grip. And then for this one, we're going to focus on just the subxiphoid view, again, to get the probe in the patient's hands, or the student's hands. Other ones are your parasternal long axis, your parasternal short axis, or your apical four-chamber. Again, curvilinear or linear probe, you could also use curvilinear probe if needed. Overhand grip is important, and then go right in the patient's subxiphoid area. Again, you want to go right under the subxiphoid, not on it. It's going to be more comfortable for your patient and allow you to get a better picture. So I like to start an indicator towards the patient's right shoulder. Find your liver first. That's going to be your acoustic window. So you have your liver, and then your IVC, and then follow your IVC up until it drains right into the right atrium. And we like to think of our heart as right and left sides, but essentially it's more of an anterior-posterior. Your anterior being your right side. It's always going to be in your near field. So you have your right atrium, right ventricle. And then posterior is going to be your left side of your heart. And far field, left atrium, left ventricle. Other things you sometimes can see are your aorta, and then the descending thoracic aorta is always going to be posterior to your left atrium. So when you're scanning, again, your interpretation, looking for cardiac contractility, just kind of a global picture. Any effusions that you can see around the heart here, this is your normal physiology, so you're not going to see any of that. When you're sweeping through, just sweep through the entire heart, because effusions can kind of hide anywhere. It's not always going to be obvious. So once you've gone over normal physiology and the acquisition of the image, you can switch to Tamponade on the HeartWorks on the Eve. And then again, we're just focusing on the subxiphoid view. Some more indications for the subxiphoid view are during a code situation, during chest compressions, you can check for any cardiac contractility, and then also to assess for any Tamponade like we're going to do here. So acquisition's the same, overhand grip, or indicator towards the patient's right shoulder. Find your acoustic window in the liver, and then sweep up. And here you can see a pretty significant effusion around the patient's heart with the anechoic fluid, with the pericardium being hyperechoic on the outside. And you can see this patient, for it to be considered Tamponade, is going to have pretty significant hypotension. Other things on the Beck's triad are JVD, pulsus paradoxus, and then specific findings on your ultrasound on the right ventricular free wall. You can see it's kind of tenting here, not really contracting. Other things you're going to see are collapse of the right side of the heart during diastole, during relaxation of the heart because of that pressure from the pericardium pushing on the ventricular free wall. So management of this in the Tamponade situation is you can use a subxiphoid view to perform pericardiocentesis. This is going to be your best image and location to perform that pericardiocentesis. Less likely to puncture a lung, cause any pneumothorax, which is going to make the situation worse. If this effusion isn't really too clinically significant, not causing Tamponade, and it's inflammatory, you can give things like colchicine, NSAID, steroids. If it's infectious, then treat that appropriately with your antibiotics, antivirals, and antifungal. And then with any additional time, you can run through different imaging of the heart, like parasternal long axis, short axis, apical four-chamber, or you can play around with the Eve a little bit, different pathologies and physiologies.